Well, welcome everybody who either just joined us or didn't or wasn't perhaps listening to me blather on before. I'm Stephen Carnovale. I'm a professor of supply chain management at RIT. And with me, we have Ryan Burke, who's going to introduce himself in a moment. This is going to be what I hope to be a fun conversation on really the turbulent and chaotic and I don't know if there's another adjective that would suffice, but the crazy times that we're facing in healthcare related or driven supply chains amidst COVID-19. So this webinar is being jointly sponsored by RIT's Masters of Science in Global Supply Chain Management, as well as the Upstate New York Healthcare Supply Chain Management Organization. So with that, I will turn it over to Ryan to introduce himself. And then we will get things going. And if I could, I'd just ask everybody in the audience to keep their microphones on mute. Any questions you'd have, please feel free to put them in the chat box. And towards the end of the conversation, Ryan and I will address them in turn. So without further ado, Ryan, I'll hand it over to you.
Great, thank you, Stephen. Happy to be on the webinar this afternoon. Really looking forward to sharing all that we've learned since our worlds really have been rocked with COVID in March, and we're still fighting the fight into the new year here. Certainly getting a lot of press around vaccine distribution and other things that I'll touch upon a little later on. But by way of background, as Stephen said, I'm here representing the Healthcare Supply Chain Association of Upstate New York. I serve as the president of that organization. But before I tell you a little bit more about that, I'd love to just share a little bit about my background. Currently, I serve as the vice president of strategic sourcing at Pandion Alliance. Pandion is a regional group purchasing organization that's headquartered here in Rochester, New York. For those that aren't familiar with what a group purchasing organization is, we could probably spend a whole nother hour webinar on that topic alone. But in a nutshell, we are a solution provider and a buying group for our members. And our members are made up of both healthcare and non-healthcare facilities. We have 5,000 of them in over 47 states across the country. And we contract and source products and services for our members. And we use aggregated volume to negotiate with suppliers to ensure best pricing and best services for our members. That's my current role, and just a little history on my professional development. I spent 10 years before joining Pandion at Rochester Regional Health, where I held various roles within the supply chain. I started as a buyer in the corporate purchasing department at Rochester Regional. I progressed on to become a buyer planner, which was more in line with what you'd see in manufacturing from a job title perspective. I then had a chance to leave corporate purchasing and join the supply chain logistics team as their operations supervisor, overseeing the fleet management team to include couriers and medical supplies being shuffled across their entire supply network. From there, I entered a more, tactical role as a materials manager at Rochester General Hospital, the flagship facility there at RGH, or at Rochester Regional Health. And then before I left, I was the director of materials management at Rochester General Hospital as well. And I've been with Pandion for 2 years now. The first year was spent learning about GPOs and kind of the other side of the table from the healthcare perspective. And then most recently, this last year has been dealing with COVID and really just supporting our members through what's what's happening in our worlds. So happy to be here and excited to share some things we've learned.
Yeah, no, absolutely. That was a good introduction to kind of the context and the background. And I think, hopefully those members from your organization, either the Healthcare Supply Chain Organization or Pandion, would be interested to take a look at our master's program. It fits nicely into the things that are happening now, right? It's STEM designated, which means science, technology, engineering, and mathematics. So heavy analytical focus, 12-month-long program that covers kind of how to navigate in these changing times. So I'll be happy to talk more about that if there are any questions. But I don't want to be too ad heavy, so let's get right into what we're talking about. So we're almost a year into this thing, at least in terms of the way in which COVID has impacted domestic supply chains directly. That is, I mean, indirectly, we had buildups at the port of Los Angeles when shipments weren't coming in from China or if they're being quarantined, and then you had chaos occurring in Europe, which bled into the freight markets here. But when you're looking at this from your standpoint, Ryan, from either the GPO perspective or even from the sourcing perspective, what are the largest shifts in the healthcare supply chain, and what led up to them? I mean, where are we and how did we get here?
Yeah, great question, Stephen, and an important one for the audience to really understand the history of why this happened in the healthcare supply chain. Because I would bet that before March, outside of healthcare professionals, no one knew what PPE was, and now everyone wears PPE in Wegmans or wherever you shop. So four key buckets that I think of here when I think of how we got here. So one is provider and supplier consolidation. For the last 15, 20 years, there's been mega mergers, not only on the provider side with large health systems and IDNs, but also on the supplier side, where large manufacturers are only getting larger, and less and less competition is in the market now because of all these large suppliers that are kind of just buying up their competition in healthcare. So you have that consolidation that's happening. You also then have historically in healthcare just an unrelenting cost pressure that's been put on providers. It could be because of some of the payer challenges. It could be because of some of the governmental challenges. But nevertheless, there's just a tremendous amount of pressure to take costs out of the healthcare system. And one of the biggest key drivers in that is the supply chain and the healthcare supply chain. If you're a supply chain leader, a supply chain director at an IDN, every year you go to the CFO's office and they say, "Here's your target for the year. Hit it and do better than it." And that's just been the status quo for a number of years. It doesn't really matter what's happening in the market. You have to take costs out of the system. So because of those unrelenting cost pressures, this kind of leads into the third bucket here, Stephen, and everyone on the call. The PPE in products, gowns, masks, gloves, that was an easy target because there are a lot of manufacturers of PPE. They got a lot of publicity that there isn't. There is, but it's just very concentrated. And so the product was commoditized. Instead of being seen as a strategic item, it was seen as a commodity. And what happened is because they were trying to take every penny out of the production cost, manufacturing became very concentrated. 85% of PPE is manufactured in Southeast Asia. So you have a very concentrated production. You have a commoditization of the product. You have the unrelenting cost pressures with the consolidation. And then kind of that fourth risk point here is the just-in-time nature of the healthcare supply chain, right? You don't want to have a lot of product on hand. And because we're trying to manufacture those products as inexpensively as possible, the suppliers don't want to hold a lot of the product either. So they're going to reduce their inventories. So they're not carrying way too much supply, especially for those publicly traded companies that have to answer to shareholders. They want to keep those inventory numbers down. So, all of those things are okay as long as you don't have a massive spike in demand, right? And unfortunately, that's exactly what we saw in March, April, May. And that's one of the reasons you couldn't buy toilet tissue, at the store, and shelves were empty for Clorox wipes because we just had this huge spike in demand. PPE was at a premium, and those were really the four factors that kind of got us to the why. Why did we run so low, and why were the headlines in the New York Times that nurses aren't safe and doctors aren't safe because they have no PPE? Well, those are truly that's the background, and those are the reasons why.
So what's interesting too is when I was listening to you, three things popped up in my mind. The first was you said if you're an executive at any capacity, you have to go into your supply chain head, whatever they may be, and tell them what the plan is for the next year, and then they say, "Great job, beat it by 10%." So one of the things that we've seen in other industries, the auto industry in particular, is these price pressures that occur. They end up leading to, over a long time, either negative supplier relations, which has bad impacts, negative impacts on your business if you had bad PPE or bad service and so on. Or we see that the price pressure will, the supplier will give them the price pressure, but what'll end up happening is the lower responsiveness, the lower quality, or anything, they'll compensate in other ways. So you have that dynamic, which you talked about, which is super interesting, combined with the other number, which is staggering. You said 85%?
That is correct.
Of PPE, 85%. So 85 out of the 100 masks that are out there come from one part of the world. So you have this power that's going on. So, those dynamics have been at play. And then, like you said, you add this consumer behavior chaos into it, stockpiling and toilet tissue. So with all that said, right, what are the challenges moving forward? How do you navigate those four pillars that you said with all of these dynamics and all these elements? I mean, what are you planning? What is your team planning for moving forward?
Yeah. So, one thing I do want to touch on is that's your first point about service levels. That's obviously the first thing that suffered was fill rate. Products were put on allocation. And again, protective allocation is fine when we're in this type of situation. It's the right thing for the manufacturers and the distributors to do. But when you're trying to work towards 150% historical allocation and they're filling at 40 or 50%, that doesn't help you at all. And that's exactly what was happening. So a couple other things that I think about here. You touched on the piece about the concentration of manufacturing in Southeast Asia, but it's very concentrated, and we still don't have clear visibility into that supply chain in the healthcare world. So healthcare organizations historically are so dependent on their distributors and their A suppliers, I'll call it, those key manufacturers, that they really don't have clear visibility into raw materials. The SMS product that's used to create a mask or a gown. We have limited visibility into that in the healthcare supply chain. That's just because you're so focused on your relationship with your distributor and making sure that your distributor is fulfilling their commitments, that you don't really look beyond the distributor, which is a risk point for the healthcare supply chain for sure. Another thing that you spoke to, the unprecedented demand, how that supply and demand was out of balance with the toilet tissue. We saw a whole bunch of reactive purchasing with consumer behavior. We also saw it in the healthcare supply chain. That's been a historic challenge in the healthcare supply chain is hoarding and stockpiling behaviors, and that was the first thing that happened when the shortages and when the allocations hit. And then two other things that I want to touch on. You hit on some of the embargoes that were taking place with the exports. The manufacturing was shut down. There were sterilization concerns that were of impact here. There was price gouging that was going on. There was also, we've never really seen this before, but there was like nationalistic behavior that was occurring. Countries were not exporting PPE. They were hanging on to it for themselves. Some of that was just the timing of where the virus was hitting and who was hitting the hardest. But that's challenging when you're trying to demand plan and you're trying to forecast for the product you need to bring in to keep your health system viable for weeks or months, and your burn rate has gone up 100x, and it's a complicated equation, and it was a very complicated equation for health systems. And the other challenge that we saw was this idea of bad actors or a gray market activity. And there was a recent 60-minute special on it. And I encourage the audience to just quickly look it up on Google and watch it if you haven't. It's a 15-minute episode that really just highlights some of that gray market activity. There were just a ton of bad actors, as we call them, asking for incredible quantities, right? Like 1 million minimum order quantity, or extreme pricing. In non-COVID times, an N95 mask cost 3 cents. During the first surge, a mask was $5. So it was just way out of balance. There were bad actors that were asking hospitals to wire transfer money, and which is never a good practice. You don't want to. We actually, because of this, we ended up being the vetting arm for a number of our members, healthcare members, meaning we would physically call all these brokers, and just make them take proof of life video that they actually had the product on hand, and it wasn't just a middle person or this type of bad acting behavior. And that activity, believe it or not, still continues today. We've gotten a lot wiser to it, and we know exactly what to look for. I'll talk a little bit about some of the sourcing strategies we used a little later, but it was really just this gray market that was a whole new level of complexity that it was just very unfortunate to have to navigate with everything else that was happening.
Your story about proof of life videos reminds me of like a Mel Gibson movie or something like that. My goodness. Well, and the other interesting thing too that is, I don't know if it dovetails from or is operating in parallel to, it's like the constant pressure of thinning inventories so as to minimize costs, right? So you have this whole JIT thing, but really JIT just pushes the inventory one step back in the supply chain. So, and I'm thinking about this as you're talking, which leads me to the next question. What do you see as the role of strategic sourcing, broadly defined, in terms of getting us ready for the next one of these, right? Because we now know, I don't think there'll ever be a PPE shortage ever again, because now we know what happens when there's a too thin of an inventory. But there'll be another thing that we don't have enough of. So from your standpoint, as a leader in strategic sourcing, what are you thinking about? What strategies are you employing to hedge against the next thing that's going to be in demand, whatever that might be?
Yeah, so if you don't mind me answering that kind of in two parts, I'd love to just share a little bit about some of the history too of what we actually did, and then to help members source PPE, and then I'll talk about what I think will really happen and what we're going to be doing moving forward. So that first piece we executed forward buys through an accelerated sourcing program. So a traditional sourcing cycle, during non-COVID times, let's call it about 9 months to a year. We condensed that down to a couple weeks to identify suppliers, identify inventory, and then take that through the entire sourcing cycle and have product show up at a facility to be consumed. And used by the nurses and the doctors that needed the PPE. So that accelerated sourcing activity was interesting because while we had bumps along the road with some of the contractual pieces, right? And you always want to make sure that that's aligned and appropriate from a legal perspective when you're sourcing. But we were able to source product very quickly and a lot quicker than we traditionally thought we could. So do I think we could source, a little more efficiently and streamlined in the future? Yeah, absolutely. I think there's balance we need to take there because we don't want to expose our organizations to risk by moving too quickly. But I think the traditional, you wait a month after you receive an RFP and then you do the analysis, and right, we can speed some of that up. So we definitely learned that, through this. You know, we participated in a collaborative. It's called the Private Sector Supply Chain Collaborative, and we actually partnered with a number of other GPOs and organizations, health organizations, around a together response. So, you know, historically, health systems compete for customers, which are patients, right? They compete for their markets and their market share and the populations they serve. Same with GPOs. We compete for members, and certainly so do suppliers. They compete for both. We all came together when this happened in March, and we kind of put our allegiances at the door, and we shared data, which I thought was key. That there, you know, traditionally data is very siloed in healthcare. You know, everyone keeps it to themselves. It's almost impossible to share data with other systems or other networks. But we share data freely with other GPOs and competitors. And it helped because we could rebalance some of the supply chain. So if we noticed that, you know, you heard about the news stories about the ventilators. That was happening in real time, and you know, in New York City with a company that we are closely partnered with. They were, you know, rebalancing ventilators and PPE where they were needed, depending on where the surge was. Is it in the Bronx? Is it in Manhattan? And they would send the product, you know, to the area of need. That never happened in the past. There, you know, prior to COVID, that type of collaboration never would have happened. So I thought that was a very positive thing to come out of all this. And so when you think about, so that's kind of the what happened, what we did. So, you know, the data visibility, working collaboratively together with suppliers, healthcare facilities and other GPOs, and then some of that accelerated sourcing work that we did to quickly source PPE. So that's the history. And then looking forward, you know, a couple of things there. I still think data sharing could use work. And we need to think of other ways that we could, outside of PPE, share data. You know, there's a lot of data that's shared in healthcare when it comes to patient outcomes. You know, if you're sharing data on falls or eclampsies or something like that, hospital-acquired infections, there's a lot of good data out there that healthcare organizations share together. That really doesn't exist in the healthcare supply chain, other than, you know, outside of what a GPO is able to collect for, you know, an entire cooperative of members. So there, I think in the future, there's work that can be done there. And also specifically to the supply chain, I think we need to, you know, kind of obviously here, you know, as I previously mentioned, 85% of that PPE is manufactured in Southeast Asia. We definitely need to rebalance that. I don't think we need to take the 85% and put it in Texas, because you'll just have the exact same problem that you have now, just with a different zip code. So if we could just kind of balance that supply chain a little more, so it's not so stretched and so concentrated, I think we will avoid something like this from happening in the future. But I also think we need an investment in domestic manufacturing. Community manufacturing, right? You know, you take Rochester, for example, since, you know, this is where we are. What a perfect opportunity for job creation and growth if we, you know, partner with a health system and partner with a manufacturer to, you know, produce, let's say, isolation gowns for the hospital, and it's all being done right here, let's say, in the city of Rochester. So those are the types of conversations we are actually having now, and I think that's what's going to prevent us from, you know, having to live through another intense supply shortage like we did with COVID.
Yeah, you know, seeing how various companies who are either completely unrelated or even tangentially related to the healthcare industry come together and produce masks and sanitizer and things like that. You know, it was a silver lining, so to speak, to the cloud of COVID, and certainly not just within the healthcare industry, but industry in general. You're going to see, I think, lasting change structurally in terms of the way the business is conducted post-COVID. So we've kind of approached and navigated towards the end. So I'm just going to remind the audience here, as I ask Ryan this last question, if you all have any questions that you'd like to ask, or you know, hot topics or whatnot, feel free to put those in the chat. But Ryan, I'd like you to give the coup de grace, so to speak. what do we do now, right? You kind of touched on a couple different things, maybe 3 recommendations for those in the audience if they're thinking about how to work in their particular silo of healthcare, or if they want to work in healthcare, how do they deal with disruptions moving forward?
Yeah, great question to kind of wrap all this up and tie it back together. So I'll go through these in order of I guess likelihood to happen and likelihood that folks on the phone could make it happen at their local organizations, or as they're looking to join an organization after their studies at RIT, and where they can make the biggest impact. So for healthcare,
do both at the same time, right? Or study at RIT and work in healthcare. Either
or
way,
both at the same time, right? So great point. So for healthcare facilities, and if you don't represent a healthcare facility, think about other areas, or other product lines that this could be applicable to. But specific for healthcare facilities, I think I talked about how PPE was turned into a commodity and we took every penny we could out of PPE. I think PPE in general and other critical categories that are needed for day-to-day patient care need to be seen more as of a strategic product as opposed to just a commodity product. Yes, we need cost savings. Yes, I talked about the cost pressures on providers in the beginning of this segment. But clearly, as we found out, a product shortage and not having a product is certainly worse than balancing your finances just right. So changing the PPE from a commodity to a strategic product, I think, is low-hanging fruit. I also think that increased visibility downstream into the raw materials, knowledge of some of the sub-assembly production that occurs. Where does the sterilization happen? That's important to know. Where is the product being manufactured? What is the market share? Those are the things that I think folks can start working on right now as they're having conversations with not only their distributors but their manufacturers, and they go down in level. You can ask those probing questions and really start to build some resiliency back into the supply chain, and visibility, which is critical and really was missing during the pandemic. And then more broadly, and finally, kind of the third point, we really do need to rebalance the supply chain. We need that steady mix of domestic manufacturing as well as overseas manufacturing. So I think just a geographically diverse network of manufacturers is going to be that ideal state. We see that in other industries that do it well. Healthcare needs to get there for sure.
That's a great point. And when you were talking too about the way that healthcare supplies in general have commoditized themselves, I started thinking about national stockpiles of things, right? I mean, we've got a national repository of petroleum and this and that. It'd be interesting to see over the next 5 years the way in which government policy might impact the way that you all have to conduct these affairs. So fascinating stuff. I know I learned a great deal. So we've got one question from Chris Davidson. Says that you hit on this for a second with your nationalistic comment. Do you see the national/state governments continuing to take an expanded role in the hospital supply chain? I guess Chris and I were on the same thought process. So what do you think, Ryan? Do you see that happening? Do you see? Yeah,
that's a fascinating question, right? And again, at the root of it goes to what's going to happen, on the 20th of January when the new administration comes on, and then what's going to happen with healthcare in general. Is it going to be nationalized, or is it going to be the model like it is now? Specifically to the supply chain question, interestingly, I was brought in as a GPO representative for a group of states: New York, New Jersey, Connecticut, Rhode Island, kind of the states over there. There's a couple others, to do exactly what we do in the GPO world, which was share data, share ideas, aggregate purchasing volume, source product for their stockpiles. And I can tell you that it didn't get off the ground, and they really just turned it over back to the GPOs to manage for the healthcare facilities. So I don't know. Healthcare is hard, right? It's I don't know, Stephen. Did you read the news about Amazon and who are the other two companies that had that venture that they started a couple years ago to try and change and disrupt healthcare? I think Berkshire Hathaway might have been one of them, and someone in the audience.
JP Morgan, I think.
Exactly. Yeah, thank you. And that recently folded, right? Which was kind of interesting. So yeah, has the state been helpful? I'd say yes for some facilities, but I think just read the news about some of the vaccine distribution and what's happening there. I still think that the private sector really needs to drive this. And can it be in partnership with the federal and state government? Of course. Should it have been in the beginning? Yes. I know that there are private companies like McKesson that are helping with the distribution, and certainly UPS and FedEx. But I think just the traditional healthcare distributors and healthcare facilities needed a bigger role in all this. And then we can get it done, and then we can talk about changes to the system moving forward.
Well, your story reminded me of the reason about railroads, and Brendan may roll his eyes because he's heard this one before, but when the railroad industry was at its height, and if you look at state maps, particularly in New Jersey, you see various trolley routes and railroads everywhere. And you asked anybody in the railroad business, what business are you in? And they would say just that, I'm in the railroad business. When really they should have said I'm in the transportation business, because when over-the-road trucking came about, it disrupted rail entirely. So the question here with healthcare is, what business should the government be in, I suppose? And if it's a supporting role to facilitate the distribution, then that's probably what they're more suited to do, right? Then I think that's what you're saying. They didn't want to be a GPO. They didn't want to be at that capacity. But moving forward, it's going to be interesting. And the other dynamic I think that we're going to have to look at in every industry, not just healthcare, is the capacity of the supporting industries around it. So Ryan and I were chatting earlier on about a project that I'm involved in called the Logistics Managers Index, and we track activity and capacity on warehousing, on inventory and pricing, and transportation, excuse me, and we see whether these things are going up or down. And we've seen this market tighten and tighten and tighten. It's just starting to relent. Anybody's interested, they can go to the-lmi.com. But it's a crazy world we're in. And Ryan, it'd be interesting if we had a chance, maybe 6 months from now, to get back on one of these and kind of do a post hoc retrospective, and see if anything's better. So, oh, go ahead, Ryan. Yep.
Yeah, and I think this is the one that will, force some change in our healthcare supply chain, right? Because we've talked about it for years. Yep, we'll change. Yep, we're gonna, not be preoccupied with cost, and understand the total cost and the total cost to serve and utilization management. And there are some progressive organizations out there that get to that, but this was truly the event that is forcing change, and we're seeing it. I mentioned some of the domestic manufacturing plays that we saw, happen in real time with distilleries manufacturing hand sanitizer, but there's also strategic investment in domestic companies by health systems. There's been a couple health systems, large IDNs that have actually have equity in domestic manufacturers, and this is happening in Texas. It's happening with DeRoyal, who's a medical distributor, and so you're going to read these headlines, and this is really going to happen, and I think it's long overdue. And I think another important piece here is the role of the healthcare leader in the healthcare supply chain needs to be elevated. The basement to boardroom is kind of the thing that you always heard about in the healthcare supply chain, because traditionally it was someone who had worked in healthcare, maybe as a patient care tech or a clinical provider, and then they kind of fell into the supply chain. And that's why I'm glad I'm able to talk with your team today, Stephen, is because we're looking to, in the healthcare supply chain, looking to recruit the best and brightest to come want to work in healthcare and want to work in the healthcare supply chain. And, really see, if you want to help people, and you kind of have that healing gene, you can certainly do it in a support role like the supply chain as well. But that role, that supply chain leader role, has evolved over the last 10 years from a director to, we're now seeing VPs, and even the last 5 or 7 years, we've seen healthcare organizations hire, chief supply chain officers and chief procurement officers. And these positions are very strategic. They're setting organizational strategy for the supply chain, with the CFOs, with the CEO, and it's long overdue in the provider side for the healthcare supply chain. Because, we see it in pharma, we see it on the medical device side, you certainly see it in industry. And it's good to see that the provider side is recognizing the importance of the supply chain to patient care and to the healthcare ecosystem.
So it looks like we've got one more question from Brendan. What are immediate changes the system can make to improve their supply chain? Supplier diversity, perhaps?
Yeah, good one. And I know Brendan's coming from URMC and also studying at RIT. So thanks for joining, Brendan. Yeah. I mean, supplier diversity, I think I touched on in the beginning, the kind of the giant healthcare manufacturers that are out there that are just buying up the competition, because they have the capital and they have the innovation centers and so on. Supplier diversity will help that. I think it'll help our communities. The idea of investing in jobs and resources in a local community, that's what the health system is meant to serve, is the local community. And part of serving the local community is not only in health, but in employment and in jobs. The 2 health systems in Rochester are the largest employers in our area. So why not create some economic stimulus, if you will, while you're also looking to keep the healthcare supply chain balanced. Go ahead, Steve.
No, go ahead. That's it. I didn't have much.
Okay. Yeah, I don't know if that was an immediate change, I guess I would say. That will still, take a little time to get there, because there's still you still have to think about cost. You still have to think about quality of product. You still have to think about product availability. But with that, I think that health systems can be an advocate for smaller companies or diverse companies to help, share what your need is as a health system, right? Share and, work collaboratively with those smaller companies or those diverse companies to allow them to do business with you. Because the last thing you want to do, and we've seen real life examples of this, is, someone the size of URMC, tries to, shifts their volume to a local supplier and they just can't keep up with the demand, or, you don't want to put a company out of business by shifting so much demand to them all at once. So it needs to be strategic and it needs to be well thought out.
Well, one commonality that I'm sure we both can agree on is talented supply chain professionals to go into any health system or healthcare supply chain and be able to execute data-driven, decision-making for ultimate success. And I think that's probably applicable in any industry. And if COVID has done anything beneficial, it's highlighted the importance and the necessary changes to be made in healthcare supply chain. So with that, Ryan, thank you very much. This was a great conversation. Everybody who joined us, thank you very much. And again, this was jointly sponsored by RIT's Masters of Global Supply Chain Management, as well as the Upstate New York Healthcare Supply Chain Management Organization. So thanks again, everybody. This was fabulous, and the recording will be available to be distributed amongst you and your team. Thank you.
Great. Thank you.